Well, let's go on with PET-guided therapy, or what we call response-adapted therapy. Recent evidence, which has been summarized in the late NCCN Hodgkin lymphoma guidelines, support and recommend the use of PET in assessing response after 2 cycles of therapy. At the end of therapy, pre-high-dose therapy and after high-dose therapy. Assessment of response should be done using the Deauville criteria, which I will show in a later slide. In early stages, PET can be used and has been used and is being used increasingly to try to avoid radiotherapy. In advanced stages, PET has been used and is being used to escalate therapy and or to de-escalate therapy after the first 2 cycles. PET can be used to guide biopsy, and PET can be used to avoid bone marrow biopsy, as pointed out by L. Galali, here it is. However, PET should not be used for follow-up. Most relevant to the IA population is the possibility of minimizing toxicity. Here are the Deauville PET criteria, as published recently. And what do we do with these numbers now? Well, if you have a score of less than 3, the patient is doing fine, let's go on as planned, and perhaps if you are very worried about side effects of radiotherapy, you could think about dropping radiotherapy. If the score is 4, begin to get worried. Perhaps you should think about intensifying therapy. If you have a score of 5 in a site involved, perhaps you should rebiopsy that site and consider the disease as refractory. So, practice changes. 200 years ago, we spent most of our time looking at patients. We spend most of our time today looking at a screen with the Deauville criteria closed by hand. Let's go on with therapy. I'm going to begin with early stages. Early stages, that is, clinical stage 1 to 2A, with or without risk factors, gold standard is combined therapy. That is, 2 to 4 cycles of ABVD, followed by 20 to 30 grays radiotherapy. Some groups, especially groups around Germany, the German Hodgkin study group, would recommend the 2+2 plus radiotherapy approach. However, although we've got a very good standard, there are at least 3 early-stage trials trying to decide whether we can omit radiotherapy using PET. These trials have been reviewed recently. I keep on pausing the wrong. These trials have been reviewed recently. They have published results in the last year. The H10 trial, very recently, I would recommend to you the review of Maya. Before dropping radiotherapy, let's think a bit first. Beginning with radiotherapy-related issues, we have decreased the dose of radiotherapy, at least for patients with no risk factors. Other approaches that might decrease the dose that adjacent tissues received, is this working? Yeah. Are listed here. For instance, the use of the involved node versus the involved region approach, using the post-chemotherapy volume. There are other techniques. I'm no expert, I'm no radiation oncologist, but you may find a review in Hodgson. Planning can be done in deep inspiration, decreasing the dose to the lungs in this way. Well, with combined therapy, we're getting these very good results. Overall survivals over 10 years, over 90% at 10 years, and EFS in the long run, a very good figure too. We have decreased the radiotherapy dose. We have decreased the field size, and we are using new techniques. And this is going, no doubt, to decrease long-term side effects. Omission of radiotherapy is going to increase the relapse rate by about 2 to 6%. And these are not my numbers. These are the numbers that have been calculated from the RAPID and the H10 trials. So, are we going to radiate everybody just to avoid a 2 to 6% relapse rate? Before rushing to drop radiotherapy from your schemes, look at this very alarming report from the States. This is a database review, and it has been published only in an abstract form. I have not read the article. These people have reviewed the results of over 5,000 Hodgkin lymphoma, early Hodgkin lymphoma, and conclude that there has been a reduction in the use of radiotherapy in the States among AYA, but this reduction in the use of radiotherapy has not resulted in an increase in survival. On the other hand, it has increased overall mortality and has not decreased the risk of second malignancies. So, outside clinical trials, decisions on radiotherapy should be taken considering age, sex of the patient, fields, and talking it with the patient, of course, and your radiation oncologist. How do we treat advanced stages? Advanced stages in Hodgkin are treated with chemotherapy. The role of intensive regimes remains to be debated. Stanford is no better than ABVD. There are at least 2 randomized trials. BCOP escalated might be better, and it is being used by most groups in advanced high-risk Hodgkin lymphoma. There is no role for radiotherapy if the patient is in complete remission. And again, PET has been used to escalate. That is, if you begin with ABVD and the patient is not in remission after 2 cycles, you may escalate, and that is being done, to, let us say, BCOP escalated. If that is the American approach. In Europe, most groups prefer to begin with BCOP and de-escalate to ABVD after 2 cycles of therapy. I refer you to the papers. How do we treat relapse disease? Standard therapy for relapse disease in Hodgkin is short second-line chemotherapy followed by high-dose therapy, as shown many years before. Conditioning regime most widely used is the BEAM scheme. However, some groups use CBV. There is again limited role for radiotherapy. Most groups in Europe use schemes such as ISHA, DAP, or IGEV. Most groups in the States use the ICE. Response rates are about 60 to 80%. Do we have anything new from the point of view of conventional chemotherapy? Yes, we have the intensified regimes, such as the DAP-14, that is given the DAP every 14 days, the use of the augmented ICE as proposed by Moskovitz, that is increasing the dose, or the use of the 2+2 approach, again by Moskovitz, changing the scheme to another combination if the patient is not in remission after 2 cycles. However, there are no comparative studies. The Gem-Bumel combination has given very good results as used as high-dose therapy. However, it has not been compared directly with BEAM and is more toxic. Relapse after high-dose therapy is usually treated with allogeneic stem cell transplantation. There are 11 studies published in the last 5, 6, 8 years. The last one, it is the one by Sureda. So these are the numbers. Well, we may discuss a lot about these numbers, but I have tried to summarize what I have found in the literature. As I have said before, in early Hodgkin, we may get overall survivals over 90% with very good PFS. Advanced Hodgkin does not go, well, it's rather, we've got rather good figures too. But the situation is not so good in this area. We need something better for patients with relapse disease and especially for refractory Hodgkin lymphoma. Allogeneic stem cell transplantation is doing well, fairly well. Patients do not die of the procedure, but relapse rates are very high. Well, do we have anything really new and not chemotherapy? If you look at this slide, which is an American one, you will see that combinations of HIDACs, IMiDs, or mTOR inhibitors are not performing very good. GVD combinations are not new, so we are left here with brentuximab vedotin and bendamustine. Probably bendamustine is not shown in the previous slide because it is an American one, and bendamustine is a European drug. Brentuximab vedotin, as you all know, it's a modified anti-CD30 antibody, which is being used now in refractory setting, as there are many publications in the last 2 years, and the drug achieves response rates of over 70% in the relapse setting. The drug has been used in children, as published recently by Locatelli, with the same schedule and the same dose. Bendamustine is achieving response rates of 50 to 60%, but that's very recent, have not more data. There are many ongoing trials with brentuximab vedotin as frontline therapy, not in the relapse setting. It is being compared with ABVD, and the German group is testing a combination modification of the BCOP scheme versus the traditional BCOP, combined with BV, of course. There are at least 3 groups using brentuximab vedotin pre-high-dose therapy. The German group is using BV brentuximab with DAP. The Spanish group, the Joe Spanish group, is going to use BV with ESHAP, and the Sloan Kettering is using brentuximab with the augmented ESA. We have no results of these trials yet, of course. Are we going to be able to drop allogeneic stem cell transplantation from our protocols? Well, let's hope that will be the case. It is better to cure Hodgkin lymphoma with a combination of chemotherapy and an antibody than going on to allogeneic stem cell transplantation in third line. Well, just one slide on lymphocyte predominance Hodgkin lymphoma. The subject has been reviewed recently too. As you all know, lymphocyte predominance Hodgkin lymphoma is a CD20 positive B-cell lymphoma, which perhaps shouldn't be grouped among the Hodgkin ones. The disease responds very well to therapy, but relapses and has a high risk of transforming into diffuse large B-cell lymphoma. Initial stages are treated with surgery in very young people, with radiotherapy, and more recently with rituximab. Advanced stages are treated with combinations of chemotherapy and rituximab. The results of the MD Anderson are very good with a combination that we are using for B-cell lymphoma. Multiple relapses should be offered high-dose therapy again with rituximab. The role of rituximab, however, remains to be determined because the patients relapse, but it is a good option for very young people. Well, and last but not least, a subject that is beginning to worry us even more than therapy: late side effects of therapy and follow-up. Before going into the numbers, note and remember that most Hodgkin lymphoma patients will be cured of the disease. Relapses are rare beyond 5 years from therapy, as shown in this very well-known graph. We are seeing now complications of therapy given more than 20 years ago. So the risk of complications might be decreasing. However, the good news is that the risk of second malignancies is decreasing, but the risk of heart damage is increasing. Some of the most frequent complications could be prevented by a careful pre-therapy, heart, lung, and fertility assessment. I have not much time to go into details. For those of you who are interested, I would recommend these 3 publications. Let's begin with the non-malignant complications. And here, top of the list is cardiovascular disease. Radiotherapy damages the coronary arteries, causes valvular damage, especially to the aortic valve, and causes arrhythmias. The risk is dose-related. Chemotherapy damages the myocardium and increases the risk of heart failure. The risk of any cardiac event may be as high as 34% at 30 years from therapy. Other factors that may increase the risk are listed here, but they have not properly prospectively assessed. After heart comes lung. Chemotherapy, mainly bleomycin and busulfan, damages the lung. Radiotherapy does too, causing fibrosis and decreasing the diffusion capacity. Damage is dose and age-related. The risk may reach 2% at 20 years. It has been reported that the use of G-CSF increases the risk, but there are no recent reports. And we don't use many G-CSF with most of the combinations that we use in Hodgkin. As much as 25% of people given radiotherapy, having received radiotherapy to the neck, develop abnormalities in TSH, and most of them will require replacement therapy. This is a very early complication, and the risk increases with age. Infertility is related to radiotherapy to the abdomen, the use of alkylating agents, and high-dose therapy. Males are at increased risk, and people at older age when treated are also at increased risk. Bone complications have been reported, but they have not been assessed in a prospective way. Let's move to second malignancies. Second malignancies after Hodgkin, after therapy for Hodgkin lymphoma, are related to radiotherapy, to the use of alkylating agents, to increasing age at therapy, to female sex because of the risk of breast cancer, and other factors such as smoking. High-dose therapy per se does not appear to increase the risk of second malignancies, and the risk may be as high as 13 for chemotherapy or 18 for combined therapy at 20 years. Here, top of the list comes breast cancer. If you look at the papers reviewing the subject, sometimes the risk is evaluated as IR, and others it is referred as CIs. I will give you the 2 numbers whenever it's possible. CIs for breast cancer in females, of course, may be as high as 20% at 20 years. This is a meta-analysis and gives an IR for combined therapy of 23, which is very high, and with a median latency of 17 years. Menopause decreases the risk, but young age at therapy increases the risk. Females at higher risk are those that have received radiotherapy under 20 years. After breast comes lung. CIs here are 13 for chemotherapy and 18 for combined therapy, as reviewed again in a recent meta-analysis. Irs are 10 and 14. For acute leukemia and therapy-related myelodysplastic syndromes, we've got 2 very recent data. Expressed as IR, there is no difference for patients who have been treated with chemotherapy or with combined therapy. Expressed as CI, it is 0.9%, peaking at 31 months. For non-Hodgkin lymphoma secondary to Hodgkin, we've got recent data too. The non-Hodgkin lymphoma is related to radiotherapy and chemotherapy, and the risk reaches 2.5% at 15 years. So, with these numbers in mind, it is no wonder that most guidelines are beginning to include follow-up recommendations. First of all, patients with Hodgkin lymphoma should be informed of the need to be followed. Most of them are not even aware of the fact. You have to inform the patients. You have to give them a treatment summary, and patients should have written follow-up recommendations. Patients should be counseled to lead a healthy lifestyle, and they should be counseled and referred, when needed, for fertility, menopause, and osteoporosis issues. Patients who have had radiotherapy to the abdomen or have had an splenectomy should receive vaccines and prophylaxis when indicated. And we recommend the flu vaccine to all of our patients. Most of the guidelines do not recommend doing image techniques beyond 5 years from therapy if the patient is in complete remission. However, patients should have an annual checkup with a complete blood count, chemistry with lipids, TSH, and cardiac biomarkers. Screening for second malignancies depends on age, sex, therapy received, and it is well specified in the guidelines for breast cancer. Female patients having had radiotherapy to the chest should have an annual mammogram and once a year, beginning 8 to 10 years after therapy or age 40, whichever comes first. Patients at highest risk, that is, female, very young patients having received radiotherapy before 20, should have MRIs. Chest X-ray are recommended periodically, and patients should be instructed in skin and breast self-exam. Cardiovascular disease is best prevented by doing an echo and an ECG pre-therapy, after 5 years from therapy and later on, depending on the results. Carotid ultrasound is recommended if the patient has received radiotherapy to the neck. Ideal would be implementation of national follow-up guidelines, as done by the Dutch in the Dutch Better program. If you can read Dutch, have a look at the vibe. So, we may conclude that Hodgkin lymphoma poses unique challenges. The disease has got an excellent prognosis and is no doubt going to improve further with the use of PET-guided therapy, new radiotherapy techniques, and using perhaps drugs such as brentuximab in early phases of the disease. Follow-up guidelines should be implemented. I am sure we will be able to find a balance between efficacy and toxicity. And that is all. Thank you very much. And if you have any questions, I'll be very happy to answer them. Hope I have not been very boring. Nobody's answering. Yes?
Thank you very much. It was an excellent review, and I'd like to ask for a follow-up in young women. because I don't think that to do for the young women mammography once a year, it is another radiation.
Yes, I'm aware of that fact, but
yes, so we are doing for the young ladies over 25 years of the age once a year ultrasonography, and only if there is any pathology on ultrasonograph, then we are indicated MRI, but the mammography is the last possible method.
It depends on where you're practicing, because in some countries and in some hospitals, it is very difficult to get an MRI for screening of breast cancer. That is what it is listed in the guidelines. Of course, MRI is much better, and if your radiologists have a good expertise in echo, that's a very good option. That's what's listed in the guidelines. However, have a look at the figures of breast cancer. It is reaching 20% of young women at 20 years. So it's very worrying. I would be much more worried about the risk of breast cancer induced by radiotherapy than about the risk of breast cancer induced by the mammograms. But anyway, it depends on the place where you're working.
Isabel, thank you very much for your talk.
Yeah,
it was a shame Dr. Wallace couldn't come, but for a patient with 16 years old with Hodgkin lymphoma that goes to a pediatric unit or to an adult hematology unit, is there a lot of difference in the treatment?
Well, that depends on your radiation oncologist team. We discuss all the cases and assess the risks. It depends on your equipment. We've got thermotherapy, we've got proton therapy, and not all the hospitals have those techniques. So if my radiation oncologist tells me that it is safe, or that the lung is not going to get much radiation, the breast is not going to get much radiation, we go ahead. It depends. I cannot give you, that is, the gold standard is combined therapy. But of course, I would be very worried if I had to give radiation to a female under 20. I would discuss the matter with care with the radiation oncologist.